everyone. As Scott said, I am clinical adjunct faculty at the Eye and Vision Center at MCPHS University School of Optometry. So today I thought I would come at this from the point of a low vision exam, since that's what my specialty is. So simply stated, functional vision to me is the way that the body's visual system, which includes the eye and the brain, interacts with the surroundings in order to accomplish activities of daily living. Now, for those of us who are essentially normally sighted, the visual system works pretty well to accomplish these activities. For those patients who have a visual impairment or any degree of visual loss, the system doesn't work so well. So that's where we all come into play, along with a multidisciplinary group team, which you are a part of, I imagine. It includes physicians, OTs who are trained in vision rehab, orientation and mobility instructors, assistive technology specialists like here at New England Low Vision, TVIs, social workers, and the list can go on. So that's really the model that I like to follow when I'm referring patients out for additional help. So I thought that I would kind of bring you into the clinic and tell you how we approach our new low vision patients. Because a lot of times they come in and they really don't know why they're there. They think it's a regular eye exam, and we need to explain to them exactly what's going to happen. So I usually begin by welcoming them and telling them that their referring doctor thought that they would benefit from a low vision exam, which I think is synonymous with a functional vision exam. And I tell them that it's a little bit different exam. Some of the things that we do will be very familiar to them, but other tests and data that we collect will be a bit different. So what's the difference? Well, if you come in for a routine eye exam, like most of you have probably had, the emphasis is not only correcting your vision with a pair of glasses, but it's an ocular health assessment, looking at the health of the eye, looking for disease, treating disease. This is a little bit different because our focus is not primarily on that. We want to be able to spend most of our time on the functional vision aspect. So we don't spend a whole lot of time dilating patients and looking at health assessment. I kind of leave that to the referring doctors. So having said that to the patient, I tell them that our goal, and these exams are very goal-orientated for us and the patient, is to help them see the best they can to do what they want to do and what they need to do. Now, visual acuity doesn't always correlate to visual function, as a lot of you probably know. We can have patients in the clinic whose vision you would think is pretty good, 20/20 to 20/40, even 20/70. 20/70 allows you to drive daytime in Massachusetts, so why should a patient have a problem? But there are things that can occur in their functional day-to-day lives that are interrupted because of another impairment. So they may have decreased contrast sensitivity, and that may be because they have glaucoma. They may have field cuts because they have suffered a stroke, yet their central vision is still 20/20 or 20/16. They may have photophobia because they've had a traumatic brain injury or have suffered a concussion. So we see patients, with very seemingly normal vision, all the way to patients who have been registered as legally blind. So the ultimate goal, again, is to meet the goals of our patients. And patients have a lot of different goals. And we usually start by asking them, if they can't enumerate what their goals are, what it is that they're having difficulty with. And we usually start with the near vision. There's a lot of tasks that may be giving them difficulty. Simply reading, that's usually at the top of everyone's list. Reading tags, labels, menus, mail, newspaper, church bulletins, you name it, patients will have difficulty in this area. Distance vision, they're having trouble seeing the TV, seeing faces, driving, signs in stores, the fast food menu at a Starbucks or a McDonald's, aisle signs in the grocery store. They may have things that are bothering them as far as lighting goes. They may be bothered by too much light, too little light, harsh glare, decreased contrast. And they may have trouble ambulating because not only their field loss, but also their acuity. The one thing I do try to do right at the beginning of the exam is temper expectations about glasses. Now, everyone comes to the clinic and they want the magic glasses, and we would love to give them that. And so I explain to patients that our first and foremost goal is to give them the best prescription that we can. But I emphasize the fact that it's not always about glasses. Glasses will only do so much, and if they're enough to achieve their goal, that's great. But if they're not, and I try to keep it positive here, that's the reason that they're here, because we take the next step. We offer devices, strategies, techniques, whatever it takes to help them do what they would like to do in their activities of daily living. Now, I can go through the full exam and show them every device in our arsenal, and ultimately there are times where they say to me, "But you're going to give me a new pair of glasses, right?" So that's always a little frustrating. I know we probably have all heard that. But again, I try to keep it positive and show them the things that will help them. I would say the most important thing sometimes, and it sometimes sounds really simplistic, but lighting is often a patient's best friend. I mean, we can all appreciate good lighting. And I tell the students this all the time, that just instructing the patient on how to use good direct illumination can sometimes be the only thing that we do for a patient, but it makes a huge difference. So they hear me say time and time again, "Okay, Mrs. Jones, you can't rely on your nice overhead lighting or your pretty side lamps. Oh, but I just got the new LED lights and they're everywhere in my home." I'm saying, yes, that's great, but you need a light pointed directly on what you're looking at, perpendicular to your reading material. And we demonstrate that to them, and lo and behold, the newspaper all of a sudden becomes readable. And I know it sounds so simple, but sometimes that's all it takes. The other thing that I tell the students time and time again is never underestimate the power of a filter or a tint. So what do tints do? Well, if a patient is scoring poorly on a contrast sensitivity test, we know that maybe introducing a tint, particularly a yellow tint in most cases, will help increase contrast. So all of a sudden that newspaper, which is kind of gray on gray, becomes more readable because we've increased contrast with a yellow tint. A TBI patient or a post-concussion patient typically will favor a blue tint because it makes them more comfortable. I always tell the story about a patient of ours who came in and she had macular degeneration, and every time she went into a big box store, the overhead lighting was just so harsh, she just couldn't manage it. It was just too distressful for her to be in a store. So we tried some of our FL41s, which is kind of a light plum tint for those of you that aren't familiar with it. But any of the light plum tints usually work pretty well. And she came back for her follow-up, and she was practically in tears, and she said, "You've changed my life." And I'm like, "Oh, well, I'm glad. So what device is?" No, it wasn't the device. It was that tint you gave me, because now I can go into a store and I'm comfortable. I can do what I need to do. And that was just such a great example for the students that sometimes it's the simple things that make the biggest difference. We also have a lot of our patients, particularly with macular degeneration, who say to me, "Gee, you know, I can't sign my name on a straight line. I go uphill, I go downhill. I can't do my checks because it's all over the place. I can't write a list out for my daughter to go grocery shopping because it's such a mess." Well, you know, we've got all this technology, but the one simple thing that makes a difference is a signature guide, which, you know, some of you may be familiar with. Some of us call it typoscopes, but it's just this little window that you place on a straight line so that the patient can write their name straight or make a list straight. So again, a lot of this is simple. It certainly gets a bit more complicated when we start introducing devices, but we do try to keep it simple at first. So one of the things that I'm pretty adamant about, I would really like my colleagues and physicians and teachers, anyone who interact with patients, to really recommend that patients come in for an evaluation sooner than later. So in other words, if patients are telling their ophthalmologist that, you know, they're having trouble reading or doing a particular task, I'd rather see these patients earlier than later, because they have some functional vision available now, and if it changes, at least they've been introduced to what's available to them at a low vision clinic. So that's something that I've kind of been a cheerleader for, and it's gotten better. People are making earlier referrals. The saddest thing is when you make a referral at the point where the patient is legally blind and we don't have a whole lot of functional vision to work with, or not as much as we'd like to. And I'm just glad that they get there, because way back in the day when I first started doing this, patients didn't even know that vision rehab existed. But the earlier the better. So if you're in a position to refer patients who have any functional vision goals or who describe any activity of daily living that they're having difficulty, go ahead and kind of get them in the system early, and I think that's going to be really helpful for them. So I think I've covered what I wanted to cover. I know it was kind of low vision 101, the Cliff Notes, but hopefully there was some good takeaways from that.